Good afternoon, everyone. On behalf of Motioli Health, CME provider of the event, welcome. This is 50 Minutes on CCA, multidisciplinary approach, an open discussion focus on diagnostic, and is the first of 3 webinars. At the end of the 3 webinars, the second and the third one will be held on September 15 and 22nd. You will receive by email our questionnaire and a satisfaction survey. The training credits assigned to this project are 4.5. We would like to point out that during the webinars, through the questions and answers tool, you will have the possibility to ask questions, and the possibility to put a like on those that you consider most interesting, in order to establish the priority of the answers. Thanks to all of you for your participation, to Insight Biosciences for the unconditional support provided, and to Professor Lorenzo Ramassa for the precious scientific direction of the entire project. Professor, now it's up to you. 50 minutes starts now. Good luck with it.
Hello, everyone. As you have already heard, my name is Lorenzo Ramassa. I'm a medical oncologist at Humanitas University and Humanitas Research Hospital in Milan, in Italy. And it's my great pleasure to welcome you to 50 Minutes on Cholangiocarcinoma, and multidisciplinary approach and open discussion. I think this topic is particularly relevant given the improved knowledge and the new therapeutic options that we have for patients with cholangiocarcinoma. So it's important to share the knowledge and to make that all the physicians, even not expert in cholangiocarcinoma, are aware of these new options and can apply them in clinical practice. From a practical point of view, this program includes 3 episodes, and today we will be talking about diagnostics, and then we will have 2 further episodes in September, one on the therapeutic approaches and one on the molecular tumor board. For each episode, we have 2 experts, one international and one national, that will be talking about the different topics, and will be discussing the most important aspects. And at the end of the 2 lectures, we will have a panel discussions, but you will be able to send questions through the chat or through the Q&A tool during the presentations, and we will address them in the end. So now we can start. Today, our international expert is Professor Chiara Bracconi from the University of Glasgow in the UK, and who will be giving a lecture on diagnostic. And then we will have Professor Nicola Normanno from the International Cancer Institute Fondazione Pascal in Naples, in Italy, who will be talking about the Italian reality. So please, Professor Bracconi, the floor is yours.
Thank you very much, Lorenza, and thank you very much for the invitation. It's really a pleasure to be here. I will share my slides. Okay, can I just ask that you confirm you see my slides? Perfectly, okay. So today we are going to talk about diagnostics in cholangiocarcinoma. Let's do this. This is my disclosure. And I thought that it would be interesting to start by looking at which are the different subtypes of cholangiocarcinoma, because they obviously will receive a different approach from a diagnostic perspective. And also in terms of population at risk, this will be different. So according to where within the biliary tract system the tumor arises, we can differentiate in intrahepatic cholangiocarcinoma, perihilar cholangiocarcinoma, or distal cholangiocarcinoma. And as I said before, the risk factors associated with these diseases will be different. In intrahepatic cholangiocarcinoma, if we take aside the choledochorial cyst, that is a common shared risk factors between the intrahepatic and the extrahepatic, but is an extremely rare disease, we can see that intrahepatic cholangiocarcinoma as the cirrhotic liver as a main risk factor with all the different etiopathogenesis from the viral to the non-viral, while in the extrahepatic cholangiocarcinoma, we may have a lithiasis. However, to date, there is only one population of patients that has been defined as a population at risk where the diagnosis and the early diagnosis should be applied. And this is represented by patients with primary sclerosing cholangitis, where also called PSC, where the majority of cholangiocarcinoma are perihilar cholangiocarcinomas. So what we really need to follow when we talk about the diagnosis in cholangiocarcinoma. We have different guidelines out there, and from all the different societies, some of which I have represented here in the slide. But I can say that at the moment they are all being reviewed, and probably we will have updated guidelines very soon. So based on what we know so far, this will be the outline of my talk, 3 different parts. The main one discussing which are the currently tools available that we can use, which are the limitations of these tools, and then where the research is going for improving the early diagnosis. So I'll start by talking about blood tests, because despite this being a very banal test, it actually can give us a lot of information, not only on the diagnosis of the tumor, but also on how we can impact the management of the patient. And then will give us a feedback on how far ahead we have to go through the diagnostic pathway. So the first test that usually the patients rely, the doctor face is the derangement of the liver function. And it already gives us information. Obviously, it has to be interpreted with other information we know about the patient. It will be different if the patient already has a cirrhosis or a primary sclerosis cholangitis. And also, it will give us information about the tumor itself. Obviously, if you're talking about a perihilar or a distal cholangiocarcinoma, this can reflect the jaundice, that can be reversible, but we also need to be taken into consideration a derangement which might be irreversible because it represents a liver replacement by intrahepatic cholangiocarcinoma, in which case probably the diagnostic pathway can be affected. The nutritional status is quite important, and we know the albumin has obviously quite an important value in terms of prognosis. And when we look at full blood count, we, apart from looking at cholangitis, we need also to pose a particular attention to the immune cell distribution, because we know that this can have an impact on prognosis. In fact, I want to share with you some data that we have generated in collaboration with the University of Modena when I was still at the Royal Marsden. And you can see that integrating the distribution of the immune cells with the albumin in a prognostic score, you can actually differentiate the survival of patients with metastatic or advanced biliary tract cancer undergoing chemotherapy. So in some way, you can already identify patients that probably will not benefit very much from the treatment. And obviously, when we are talking about blood tests, we need to talk about the tumor markers. We all know that these are not properly diagnostic because the specificity is not high enough, but it's still a recommended test to be taken sometimes before we make a plan, because it can already give us information about staging and about prognosis. This is the experience of the European Network of Study of Cholangiocarcinoma, which looked at a retrospective cohort of more than 3,000 patients, where you can see that the serum level of CEA and CA19.9 are actually correlated with the advanced stage. Something that we had already noticed in our clinics, but is now on paper and data. So when we have the derangement of tests, then usually we move to imaging. Ultrasound might be the first test in many centers, where the intrahepatic cholangiocarcinoma will appear as a solid mass with possible dilation of bile ducts. Moving on to contrast, CT and MRI, I think it's really sensible to remind that what we really need to look for is a dominant liver lesion with a capsular retraction in most of the cases, and plus or minus a dilatation of the bile ducts. And the reason why I think it's still important to share this kind of a very basic information is because sometimes there is no awareness of cholangiocarcinoma. You might be aware of a recent survey at the Christie Hospital that has been published on BJC, where even in an hospital like the Christie Manchester, which is a referral center for biliary tract cancer, 40% of CUP, carcinoma of unknown primary, have actually been reviewed, and they were probably intrahepatic cholangiocarcinoma. So it's always important to better define these patients. Obviously, when we are talking about perihilar and distal cholangiocarcinoma, we have a different value of the CT and MRI. We can see the soft tissue, but we always need to pair with an MRCP to visualize the level of obstruction. The great value of a whole body CT scan is actually the staging of the disease, which will give us again information about how we can manage the patients in the future. And with these regards, I want to share the data again from a collaborative group of the HESCA led by Angela Lamarca at the University of Manchester, where she looked through the data or the radiological data of more than 3,000 patients. And got to the conclusion that probably the TNM8 stage might not be entirely reflective of what the clinical practice is. As you know, a multinodular disease in the liver, an intrahepatic cholangiocarcinoma, which is multifocal, is now defined at the stage 2 from the TNM8, which should fall here within the dotted blue line. However, we have seen that if you have multiple nodules in the liver, your prognosis is more indicated by the orange line, which understands something that, as oncologists, we already knew, but it really is important that is also reflected by the staging. So these patients are more likely to be metastatic rather than multifocal, as it might appear in other diseases like HCC, for example. And what about PET? Do we really need to give PET to all our patients when we make a diagnosis of cholangiocarcinoma? Well, if we want to define better the tumor, probably is not necessary, because we see that the specificity is not very high for identifying the primary tumor, but the specificity increases if we are looking for nodal disease, for metastatic disease, or even if we are looking for a relapse after surgery, after curative surgery. So at the moment in UK, there is an increasing use of PET scan, especially in patients who undergo either assessment for resection or in the relapse disease. Endoscopy obviously is one of these gold standard for extrahepatic disease. So we have an ERCP in distal cholangiocarcinoma, which will not only give us the possibility of diagnosis and making an histological diagnosis, but also relieve jaundice and allow for systemic anti-cancer treatment. The more up-to-date technologies like the spyglass will increase the possibility of visualize neovascularization in soft tissue and have a greater success in biopsies. What is the role in US? Well, in distal cholangiocarcinoma, again, probably we are having kind of a gold standard because it allows a better success of diagnosis and biopsies. In perialar cholangiocarcinoma, it's very difficult that the lesion can be accessed through an US and endoscopic ultrasound, but it might have a value in defined nodal disease, which is exactly the same reason why sometimes patients with intrahepatic cholangiocarcinoma might need to undergo in US. Obviously, the endoscopical moment is also a therapeutic occasion where we can put stent, which not only have a short-term complication like pancreatitis that usually are quite resolvable and reversible, but they might have a long-term complication of a tumor ingrowth within the stent. So the key question is, what can we really do at the moment of diagnosis to impact on this long-term complication? Well, in UK, Steve Pereira from UCL has run one of the only phase 3 randomized clinical trial looking at the addition of photodynamic therapy to stenting at the moment of diagnosis. And as you can see then from the slides, definitely there wasn't a positive impact on the outcome, and therefore this is not taken forward. At the moment, some centers do radiofrequency ablation, but that still should remain within research protocols and not applied to everyone. So let's move to histology. That probably is becoming one of the most important and interesting aspects of diagnosis of cholangiocarcinoma. Obviously, from a pathologist, we are asking a confirmation of an adenocarcinoma, which apparently is easy to put on a slide and like it's something that is granted, but I'm sure that we will hear from the pathologist that is not always the case. We also need to know if this adenocarcinoma is primary from the liver or if it's coming from other tumor as a metastasis, especially in the view of the new classification of the WHO of a morphological characterization of cholangiocarcinoma. These should be divided in large duct type and small duct type. So obviously we have to differentiate between metastatic disease in the first case or within HCC in the small duct type. This again is another question for the pathologist, because on guidelines we should expect a tumor that is CK7 positive, CK19 positive, and CK20 negative. I personally tend to see a lot of cases which are still CK20 positive and they are not a colorectal cancer. So it's something that still I think has to be defined. And what we really need to do in poorly differentiated adenocarcinoma is a question that is still open. But I think it's also important to understand where we have to stop with immunohistochemistry. At the moment, I think that there is an open question of using immunohistochemistry not only for diagnosis, but also for impacting the treatment, the decision that we have to take in the future. So obviously, we need to know if these patients have, which is the MMR, the status of these patients, and also given the last data, us at ASCO of the RUPFEC, probably we really need to know if it is actually positive. So probably something that will enter into the clinical practice. But the main information we need to gather from the pathology at the moment is also the molecular profiling. So you know that cholangiocarcinoma has entered the area of therapeutic, targeted therapeutics, and then we need to get specific information from the molecular profiling. So we need to know if the tumor is MSI-I, if it has a fusion of FGFR2, if it has a mutation of IDH1, and also if there is a fusion of NTRK. However, we still have a lot of more targeted therapies that seems to be quite promising in this tumor type, and that potentially will enter the clinical practice soon. So it's very likely that the list will go on very soon. I will not focus too much on the genomic profiling because Nicola Romano will give an exhaustive presentation later on. But I think that I wanted to really dedicate some slides to understand how we can get to the genomic profiling. Because it's always very easy to say, yes, we have to go for genomic profiling in everyone, but we will get to some challenges and we need to understand how we prioritize and how we overcome these challenges. Obviously, if we are talking about a tumor rising from the intrahepatic ducts, we have usually a core biopsy. So we should have enough tissue to do our histology confirmation. If we need to do multiplex immunohistochemistry of tissue, we should have enough tissue, as well as DNA sequencing and probably also RNA sequencing for the fusion. But the picture will be completely different when we move to perihilar distal cholangiocarcinoma. So I've already put that we can do a cytology, even though I would probably say that if we are looking at FNA in perihilar cholangiocarcinoma, maybe we still don't reach the success criteria in about 6 to 10% of cases. So something we need to keep in mind. We might have enough tissue in the immunohistochemistry. We have learned the lessons from the pancreatic cancer that yes, we can have a genomic profiling from EOS FNB, even though maybe we cannot expect 100% of success there. And in some cases, we might have still enough tissue for transcriptomic, but that's something that it might not be always present. And again, can we do DNA sequencing in a cytology? I mean, some feasibility data are there, but probably it's worth it to discuss with persons who run this test on a clinical base and routine base. So there is another problem about discussing genomic profiling on diagnostics, which is the fact that the tissue will be mainly fixed in formalin and embedded in paraffin. So there has been for a long time a debate if we could have good data by looking at FFPE tissue. I think we now have the answer, and definitely yes, we can. We are maybe losing something, but this is absolutely negligible in comparison to the advantage that we get from a clinical application. But the other thing that we have to think about when we look at FFPE tissue is that we really know what we are looking at. And with these regards, I wanted to share this experience of a research project we did in collaboration again with Modena and Copenhagen, where we looked at intrahepatic cholangiocarcinoma patients' liver biopsies, done diagnosis, pre-treatment, and where we wanted to assess genomic profiling and gene expression, whole gene expression from these biopsies. So we have taken two different approaches. One identified by the black box, where we took the whole biopsy, we scraped the tissue, and then we sent it for analysis. And the other one where through pathological review, we have identified region of interest with different tissues, from the normal to the interface to different heterogenic region of tumor. And then we did a multi-region gene profile. What we find is something that obviously we can all expect. The data from the whole core gene expression profile clusters in the middle between the normal and the tumor. And even though in this case, it would be like discovering water, cold water, I mean, it's really something we really need to keep in mind when we want to apply this into the clinic. So there is a more effort and interest in defining gene expression signature, maybe for immunotherapy. So it's important that we really validate how that signature has been generated upfront, and then also how we can implement that in the practice, because otherwise the data will change. So if we don't achieve enough tissue, should we pursue further tissue acquisition for molecular profiling? Well, obviously, again, the answer as a medical oncologist is yes, because that will be essential for guiding the treatment. But we also know that we will not always be successful. This is again the experience from the Royal Marsden, was led by Noreen Starling, where you can see that the success rate of NGS in routine clinical practice in biliary cancers has a high level of failure indicated by the orange bar. And if we move to the liver biopsies, we still have quite a big failure, probably indicating all those perihilar cholangiocarcinoma and those tumors which have a lot of stromal enrichment. So probably these data are specifically pessimistic, but I think that is something we need to keep in mind when we want to move it into clinical practice. And the other problem is also that of sample biasing. So this is a patient of our experience with Rugby here in Glasgow. It was a patient who was diagnosed with a liver lesion that had the radiological criteria of HCC, arterial enhancement, washout, but it was also associated with another liver lesion that did not have the same criteria and was submitted for biopsy. The results was intrahepatic cholangiocarcinoma. So the question is, how do we really need to identify this patient? Is he a mixed HCC cholangio? Is actually an intrahepatic cholangiocarcinoma that, however, has different tumor characteristics? So can we expect a genomic profiling that is different from the other lesion? Obviously, looking at ctDNA can give us partially an answer, because it will give us the idea of which is the component of the tumor that drives the progression, but still probably is an open issue. And if we need to pursue more biopsy, which is the clinical risk our patients undergo? Obviously that the hepatology community is not very keen to continue and biopsy patients because of the complications that have been in the historical casuistics. Well, this is again an experience of the Marsden, led by Khurram Khan, 522 tissue biopsies in 457 patients. And you see that the level of complications, the rate of complications was extremely low, 3%, and none of them were G3, grade 3. You can argue that these were not cirrhotic patients, so let's look at what happens in cirrhotic patients. This is a national UK audit on liver cancer patients undergoing biopsies for access to sorafenib. You see 66% of these patients had cirrhosis, but again, the complication rate is extremely low. So obviously the rate of complications increases if the patient deteriorates in his performance status and has a derangement of the liver function, but probably we need to ask if we want to submit this patient for biopsies, because here we are going back to what I said at the beginning. Every time we really need to proceed through the algorithm of diagnosis only if it is of benefit from the patient. So can we now overcome these issues with a liquid biopsy? Well, the potential answer is yes. Again, here we have our experience here at the Glasgow, as many of you have. We can detect the gene mutations, and we can monitor these mutations in the blood over time. However, when we are going to look at amplification, I think we still have better confirmation in the tissue, as we might not have the same reliability. And what should we do for RNA sequencing? We know that the gold standard remains the RNA-seq, but the data coming from Lipika Goyal presented at ASCO 2022 suggested that there might have been an agreement of 87% between liquid biopsy and tissue biopsy. So potentially there is a promise to move ahead into this topic. So the last couple of slides will be dedicated to how can we really improve early diagnosis in terms of research and where we are going. So obviously the research is going towards the development of non-invasive biomarkers, either through access to the bile or to the blood. But in the blood, we can look not only at ctDNA, but we know we can look at extracellular vesicles, microRNA, and also circulating tumor cells. Now, the question is, if we develop a novel biomarkers, who do we have to apply to? So we can't really, start to test each single individual in the population. We need to define a cohort of patients at risk. In cholangiocarcinoma, at the moment, the patients at risk identified are those with PSC, for which the guidelines recommend an annual imaging, and probably a more specific non-invasive test could be quite promising. The cirrhotic patients who, however, undergo 6-month imaging anyway for the detection of HCC, and probably they will be able to be screened for intrahepatic cholangiocarcinoma. We will have the liver fluke patients, but obviously this will not apply to the Western population. And we know that hepatolithiasis has an increased risk of developing cholangiocarcinoma, but unfortunately, this is too vague, and we don't really have a screening program in this population. So what the research directions are actually multiple here, just some examples. Some of them is increasing the reliability of brushing and looking at the bile. This, for example, is a prospective patient, PSC patients with PSC that they had the confirmation of cholangiocarcinoma in 5 because they underwent liver transplantation. And it's interesting to notice how the cytology was positive only in 1 to really underline how short we are falling with the standard of care at the moment. And the NGS was actually present in all 5 patients. The problem is that 3 additional patients were positive for NGS and apparently they didn't have the tumor. So if it is a matter of waiting for the long-term follow-up or if it is a matter of specificity is still an open debate. New diagnostic biomarkers look at methylation pattern in brushing cytology that seem to be differentiate the cholangiobrushing from the PSC, but also looking at the blood. For example, the Spanish group is quite intense, as an intense research activity on the development of extracellular vesicle-based biomarkers for PSC patients. And with this, I want to conclude and just say that, yes, cholangiocarcinoma might be difficult to diagnose, but it's really important that we integrate all the information that we get from the diagnostic test so that, the pathway algorithm forward into the diagnosis is we know when it's for benefit for the patients to continue or to stop. And with this, I thank everyone and I will stop here.
Thank you so much, Chiara, for this fantastic presentation. We will now move on to the second speaker, Professor Nicola Normanno, who will be talking about the Italian reality, and then we will have the panel discussion. Please, Nicola.
Thanks. I hope you can see my slides. And thanks for inviting me to give this talk. These are my disclosure. Well, as already introduced by Chiara, our knowledge on genomic alteration of cholangiocarcinoma have significantly improved over the past few years. And what is clear now is that the genomic profiling of extrahepatic cholangiocarcinoma and intrahepatic cholangiocarcinoma is quite different. And in particular, if you look at some genomic alteration, FGFR alteration and IDH1, IDH2 mutation, there's a clear difference between intrahepatic and extrahepatic cholangiocarcinoma. And this is very important in the management our patients because these are some of the genomic alterations that are relevant for therapeutic intervention. Here you see the different genomic alterations of cholangiocarcinoma, the prevalence, and the SCAT score. SCAT is the ESMO scale of clinical actionability of target. In other words, is a scale that ESMO has developed to assess the level of readiness of a biomarker to be used in clinical practice. Level 1 biomarkers are the biomarkers that we should test in our clinical practice, and you see this short list, including IDH1 mutation, FGFR2 fusions, MSI, and then TRAC. However, we know that other biomarkers such as BRAF mutation and their 2 gene expression are also likely to be soon updated. That Lorenza can give us some information on this. So the message at the end is that we have a number of genomic alterations that offer a possibility for therapeutic intervention in patients with cholangiocarcinoma, and of course we need to detect these genetic alterations. Now we have 2 different strategies again. On one hand, we can use a next generation sequencing, which is a technique that allows to identify all different types of genomic alterations, mutations, copy number alterations, and gene fusions in multiple genes in a single analysis, or we can use a standard biomarker test, sequencing, real-time PCR for mutations, for indels, and FISH immunohistochemistry, and reverse transcriptase PCR for gene fusions. Now, if we focus on FGFR fusions in cholangiocarcinoma, what has to be clear is that we have no available immunohistochemistry method that's been validated to detect FGFR2 fusions. And with respect to reverse transcriptase PCR, due to the fact that the number of partners of FGFR2 in the fusions is very high, it's very unlikely that we can use reverse transcriptase PCR. We will miss many fusions. This is why at the end, for gene fusions, the choice is only between FISH or next generation sequencing. But if we look to all international guidelines, the suggestion is to use multi-gene NGS panels for genomic profiling of cholangiocarcinoma. Even though, in some cases for the intrahepatic cholangiocarcinoma, you have available core biopsy, it's unlikely that you can test multiple biomarkers with the low amount of tissue that you have available just using standard techniques. Only using NGS will allow the optimization of the tissue and of the process to detect all the biomarkers. Now, what is suggested here on this recommendation from the ESMO is that you should use panels that are focused to assess level 1 alteration, and you can use either DNA or RNA-based NGS. And actually, what is very important also for the oncologists is that there are a number of different panels, and these panels can be small panels, large panels, but not all panels detect all different types of genomic alteration. When you look at the pathology report, it's important that you look at the panel that's being used to understand whether this panel is covering only some genomic alteration. Many panels are able to identify mutation, single nucleotide variants and indels. Few panels can identify copy-number alteration, and fewer panels are able to identify rearrangement and fusion. So this is very important that you must look into the report to understand whether or not your patients have really a very comprehensive and adequate genomic profiling. The other point is that the panel for fusion detection can use either DNA sequencing or RNA sequencing. Now you have to start from the assumption then when there is a fusion, the breakout point, so the point of fusions occurs always in the intronic regions. So if you want to sequence fusions at the DNA levels, you have the problem of the intronic regions. And if these intronic regions are large, you might not be able to identify the fusions. If you sequence RNA, this problem is gone, because actually in natural RNA, there are not anymore the intronic regions, and so the identifications of fusions at RNA level by RNA sequencing is much easier and adequate as compared to DNA sequencing. Now, these are general rules on how we should perform genomic profiling in patients with cholangiocarcinoma. Let's now move to the Italian reality. Now, there have been a number of documents also from the Italian scientific community. I'm showing this. It was an effort put together by the FICOG, the Federation of the Italian Cancer Oncology Groups, Cooperative Oncology Groups, and the Istituto Superiore di Sanità, let's say the National Italian Health National Institute, that put together a group of experts just to draw up some guidelines on use of NGS, and the conclusion of this group are very similar to the ESMO group. They recommend the use of NGS in selected tumors, including cholangiocarcinoma. And what has been highlighted, this is very important also in order to optimize the use of the tissue samples available in order to assess all the different biomarkers. So the Italian guidelines have really taken up from the international guidelines, and this is actually a survey data that I just received from Insight and the Celtics that was recently run in Italy. Actually, this data really related to 2021. And according to this survey, 42 labs were interviewed. And of these 40 labs, actually a huge number were providing in-house testing, and more importantly, 38 labs offered FGFR fusion testing, and actually 37 out of 38 labs are using NGS. This should be very good data, very good information for our oncologists, because if we assume that every lab should cover at least 1.5 million inhabitants, this means that we should have a very good coverage of NGS testing for FGFR in our country, because almost all the Italian population should be covered. And these are actually the different panels that were used by these labs. Not all these panels cover the FGFR fusion, but many labs are using more than one panel. Now, this is what came up from the survey, but actually we have slightly different data from our survey. The survey that was run by Diagnostics was only directed to pathologists, and this is a survey that I promoted as president of the International Quality Network for Pathology, together with the European Federation of Pharmaceutical Industries and Association and the European Cancer Patient Coalition. And this is something in which we really wanted to look at the status of biomarker testing in all European countries, and we interviewed pathologists, but also oncologists and patients, because we want to really to put together information coming from different, let's say, point of view. And these are the biomarkers that we investigated. This project really started in 2020, so there is not really specifically FGFR testing, but as you see, there is NGS, either hotspot as target panel or comprehensive panel was included in the biomarkers that we investigated. Now, to make short and long story, this is what we basically found. In many European countries, there are limitations to the access of precision medicine. Quite surprisingly, we found that in several countries, including Italy, there are still some limitations in the access to tests for single biomarkers, or the standard test. Now, the situation is almost quite dramatic for the access to NGS, multi-biomarker test. In Europe, less than 10% of cancer patients are currently tested with NGS, and there are also issues related to the quality in terms of ISO accreditation of labs and participation in external quality assessment schemes. Here we plotted the situation for availability of drugs versus standard biomarker testing, put together the quality and the access to biomarker testing. And you see, Italy is a pretty good position if you look at the availability of new drugs. I mean, we know that there is a delay as compared with EMA in the approval of drugs, but still, I mean, most of drugs are approved. However, if you look at the standard of biomarker testing, we are in a pretty bad situation. And now, if we focus on NGS, what we found is that in contrast with the data we have presented by Diagnostics, I mean, only 2% of Italian cancer patients are currently tested with NGS. This is what it really was in 2020, 2021, but I don't think the situation has changed much more than that. We found that there is a gradient of labs with the capability to perform NGS testing in the country, with quite a few labs in northern Italy, a very few centers in southern Italy, but actually most of patients did not receive NGS testing. Now, if we will focus only on lung cancer, which is a tumor type from a long time, I mean, all guidelines suggest use NGS, well, we found that about 30 to 35% of lung cancer patients are currently testing with NGS, and this situation, I think, is much worse if we look at cholangiocarcinoma. Now, what we did was to discuss, the results of this survey with the Italian Association of Medical Oncology, the Association of Patients, FAVO, the Federation of Italian Cooperative Oncology Groups, and of course the Italian Society of Pathology. And what we try, this is something we are trying to do in all the European countries, to discuss the results and trying to find suggestions that are specific for the country. And there are a few things that I think we should be introduced in order to improve precision medicine in Italy, starting from the parallel authorization of drug and test, because now what happens is that when the drug is approved, I mean, then we do not have at the same time the approval of the test. And so basically, if the patient needs a test to receive the drug, at the end, they will never receive the drug because no one cared about the reimbursement of the test. We need, of course, an HTA procedures in order to evaluate the clinical utility and the cost of the test. We need information training of all the stakeholders, and we will see why this is very important. And we need centralized data acquisition. But there are two things I think that really are needed now in our country. The first, we need to organize a network of labs in the context of the regional cancer network. So now we are struggling in order to organize in all European, Italian regions these cancer networks. And in some regions we are going through, but what has to be clear that because now genomics is always more and more important for precision oncology in these cancer networks need also networks of labs with capability to perform testing, in particular NGS tests. And the other point is that we need to identify a budget for the NGS tests, and also, we need to identify a clear reimbursement rate for these NGS tests. These are some proposals. Now there are a number of tables that are going and committees that are working on this, and we hope to have some information, additional information, some solution in the next few months. Now, but what can we do in the meanwhile, while we don't solve these problems? Now, let me show you an initiative we took. There is the Italian Register of Action on Directional Study. This is really an example of collaboration between academia and pharmas. Thanks to the FICOG, what we did was to propose a number of pharma companies to establish this study, in which basically we are collecting data from patients who receive an NGS test in the clinical practice or in clinical research, but we also are offering the possibility to perform an NGS test, a comprehensive genome profiling test, to those patients who do not have access to NGS in some, in particular, community hospitals. And these are the data are not updated. This is up to 1 month ago. Now we have over 1,300 patients that have been enrolled, and in the pathway A are the patients that really have already received an NGS test, whereas in the pathway B, more than 1,000 patients received an NGS test within this study. And as you see, we have quite a few patients with biliary tract cancer, because we recently amended the study. At the beginning, we were accepting all these specific cancer type, and one of these was biliary tract cancer. And these are preliminary data in 133 patients with cholangiocarcinoma, in which we could identify over 500 genomic alterations in 133 genes. And here shown the genomic alteration that we found in at a frequency higher than 5%. And of course, you would find TP53, but also IDH1, FGFR, and all the other players that I already showed you to be important in the pathogenesis of cholangiocarcinoma. But how do the rational data correlate with the data that I showed you before? Well, the correlation is pretty good, with the exception of FGFR2 fusions. The frequency of FGFR2 fusions in our study is only 5% versus the 10-15% that's been reported in other studies. Now, there are different explanations for this. One, of course, is that most of patients in the rational study are tested in first line, and we know that FGFR fusions is a good factor associated with a good prognosis. So, I mean, in the data of 15% comes from a number of clinical trials in which a patient was keen to access to drug in the second line. And so there was a kind of selection of patients with better prognosis and higher frequency of FGFR fusions. But one important point that we found is that in almost no of the pathological report that we received, it was stated by the patient that intrahepatic cholangiocarcinoma or extrahepatic cholangiocarcinoma. So really, this data is related to cholangiocarcinoma, and I think that it highlights the need for training of all the stakeholders. Actually, if the pathology is not informed whether it's a extrahepatic or an intrahepatic cholangiocarcinoma, it's very difficult that you can treat these symbols in different ways. Now, these are my very two last slides just for the acknowledgements, and I need to acknowledge for the ECPC, FPM, ECMPART members, staff, and all the sponsors that allowed us to perform our survey. Of course, I need to acknowledge also the Aesthetics and Insight for the data on their survey, and finally FAVO, CIEPREC, IAM, and FICOG that really work with us in order to discuss on these, I guess, quite interesting data that we collected on the Italian situation for biomarker testing. This was my last slide, and thanks for your attention.
Thank you, Nicola. Again, a great presentation. So now we have time for the panel discussion. I'd like to introduce the panelists, and then they will ask questions to Chiara and Nicola. So as panelists, we have Matteo Fassan, who's a pathologist from Padua, and then we have a medical oncologist. I'll go in alphabetical order. We have Andrea Casadei-Gardini, Massimo Di Maio, Carmine Pinto, maybe Nicola Silvestris, and Pina Zirano. Who would like to ask the first question?
My question to Nicola and Chiara is a very short question. In your opinion, which is the optimal tissue sample management and test sequence in biopsy, frequently very small biopsy? Currently, we have to consider histological diagnosis, mismatch repair, and two next generation sequencing.
Chiara, go first.
Okay. Well, thank you, Professor Pinto. As I shown in my slides, definitely this is something we have to consider, and I think it will depend on the different institutions. I mean, ideally, we can have a panel, at least a targeted panel for all of our patients, and then we can, bypass and overcome these challenges. But otherwise, I think that you'll have to go with, the diagnosis first and the immunohistochemistry panel to make a confirmatory diagnosis. I mean, for example, in Scotland at the moment, we still use the FISH because the government doesn't reimburse, and the NHS doesn't reimburse the genomic testing. So that will have to get the priority, and then we can go to the panel targeted panel next. I think that definitely the level of mismatch repair deficient tumor in cholangiocarcinoma, we are not exceeding probably the 3-5%. And I think that if we have a panel that can give us a tumor burden and MSI high, maybe we can get information from there.
Well, if you look at the Italian clinical practice, I think that it's very difficult that we can have a reimbursement for large panels for comprehensive genome profiling outside of clinical trials. So most likely, many labs will start to use or are using a mid-size panel, about 50 genes, that can cover all the genomic alteration, but will not provide information on MSI-H. I think that we can optimize the tissue by testing for diffusion mismatch repair by immunohistochemistry, and maybe LB2 if by expression, if tasvuzumab is going to be approved, and then save all the rest of the tissue for NGS, at least to test for diffusions as well from additional mutation that be relevant. This could be a good workflow for the management of these patients.
Okay.
Thank you. I think Matteo.
Yes. First of all, I have to thank Professor Di Massa for the kind invitation, for the organization of this beautiful meeting, and Chiara and Nicola for the beautiful speech. Just a small question for Chiara and Nicola, because of the significant therapeutic novelties in this field. What about a molecular reflex testing approach? Already at diagnosis, at histopathological diagnosis, and if you agree with this. Because of course we have also to think about the cost effectiveness. What about thinking only into consideration intrahepatic cholangiocellular carcinoma?
Okay, we go first. I mean, definitely we agree on doing the test as soon as possible at diagnosis, because we know that these patients can progress to first-line chemotherapy quite soon, and then we all know the logistical timing of going through the results of GNGS. I think that it's an hard question if we have to go for an intrahepatic only or for all tumor type. If we stick to the papers and the guidelines, probably we should reserve it to the intrahepatic. I am very convinced that that is not a good strategy. I mean, at least my experience is that in a lot of cases, we are not even able to differentiate an intrahepatic versus other tumor type. I mean, it's very easy when we are considering a very early tumor, and then we can go for that. But if we think at a extended, advanced, invasive masses, sometimes I think that is even difficult to distinguish a gallbladder from an intrahepatic cholangiocarcinoma. So I would advocate for all tumor types for the best benefit of the patients.
I fully agree on the reflex testing. Actually, there are some colleagues who are questioning on the fact that most of these drugs have been approved for second line. So the question is the mutation still there after the first line? Well, my answer is that based on the knowledge in other tumor types, when you have a driver mutation, chemotherapy is not eliminating the driver mutation. The driver mutation is still there. So until we will not have any evidence that chemotherapy can change the genomic landscape of cholangiocarcinoma, and I will be very surprised of this, I think that we can really recommend reflex testing, because then if you wait and the patient will go on progression, most likely you don't have the time to have the result on time, for treatment. With respect to intrahepatic and extrahepatic cholangiocarcinoma, well, the problem is that first the lab should know whether it's intrahepatic or extrahepatic. As I told you, in the national study, almost none of the pathology was informed about where the cholangiocarcinoma was really. But I think that I agree with Chiara. I mean, this is a rare disease. Why we should limit only to the intrahepatic? I mean, you can give opportunity to patients that actually will not have many chances of treatment. So I fully agree that we should extend on all cholangiocarcinoma.
And I think it's also true that we need to, acknowledge the new data that are coming in. With the approval of BRAF mutations, probably we might find that more frequently in extrahepatic than intrahepatic. So probably we need to just switch our minds.
Can I make a question?
Sure.
Okay, I would like to make a question about the Italian situation, which has been nicely presented by Nicola in his talk. Because in my view, the main risk of disparity, the main risk of inequality was until now was in terms of accessibility of drugs. But now and in the future, I think and I suspect that it will be in terms of accessibility of testing. So we have the historical example of lung cancer, where even some years after the availability of effective drugs against EGFR or ALK, we had an unsuspected proportion of patients which in clinical practice did not receive in the past years those tests. And my worry is that the same could happen also for cholangiocarcinoma. So, Nicola, you did mention the importance of regional oncological networks, which have an important role in giving local guidelines for the pathways, for the flow of the tissue and the exams. Do you think that the situation is homogeneous all along Italy, or heterogeneous, and what should be done to improve the situation? Even what should be done for on the side of the Italian National Society, the IOM, to improve this situation?
Well, actually, Massimo, we know that there is a huge difference between southern and northern Italy, but I know that even colleagues in Lombardy cannot get, an FGFR testing because NGS is not reimbursed for this indication. So, I mean, this is a problem that we have all. I think we have a lot of documents. Now we have a couple of laws, national laws that were approved past December that have introduced the concept of NGS, centers of reference, and molecular tumor board, and so on. What we need now is to speed up. Now we have to acknowledge that our health system is organized on a regional basis. So we need to really create these regional networks of labs. What is important is to indicate which are really the minimum requirements that these centers must have in order to be able to perform tests, and to push really all together to convince that we do need to switch to NGS. All the system in Italy, but I've seen in Europe, has been focused only on the drug. Now we know that to have the drug, you need to test. And now we have to completely change our approach and focus also on the test. Now, we know that because of this lack of reimbursement, Matteo can give us some insight on this. This has been really a limitation also for many pathology labs to switch to NGS. So now we have to give the opportunities, but also, we need to put some rules. You cannot accept to have 200 labs where we perform NGS on 3 samples per month. We need really to establish rules in order that we have networks that are efficient, that are cost efficient in terms also of testing, and that can provide a high quality of test. And if you perform only 3 FGFR NGS tests per month, your quality will be always low. So there are the documents are there. Now we really need to move to the application of this in our clinical practice.
Can I just add one single comment? I mean, I agree that the heterogeneity is actually, shared across all different Europe, and probably even in UK, we have a quite a heterogeneous situation. I mean, in England, the NICE has accepted and approved the drug with a matched diagnostic companion, while in Scotland, for example, didn't want to consider that. So we are still relegated to the fish. But I think that there is another point that Professor Di Maio was making, which is very important, which is the awareness of all the medical oncologists about the specific disease. I mean, while in the time between the approval and the data of the pemigatinib, we have seen that despite being able to access NGS through a program which was a national program for genomic profiling of rare diseases, a lot of centers would not send the test because they were not even aware that this was available. So it's really important to increase the awareness from the professionals as well.
Chiara, when we look at the order rate, they are not so bad. I mean, of course, there are differences from a center to the other, but I would say that the oncology community is very aware of the importance of these tests. Of course, for cholangiocarcinoma, is more focused as compared with the non-small cell lung cancer. But still, if you don't put some rules on reimbursement and levels of organization and competence of the centers, will not go everywhere. And you are in Italy, you are not in Italy, what in Italy to put a rule is always very, very difficult.
I fully agree with all of you. And Massimo, you mentioned also the IOM, the Italian Society of Medical Oncology, or other scientific society. I think this is an important task also for the scientific community, for the scientific societies, because, okay, most of the oncologists are aware of cholangiocarcinoma, of the diagnosis of the genetic tests, but I think not all the medical oncologists. So, or the medical community, because sometimes patients are seen by the general practitioners or the gastroenterologists. So I think that increasing the awareness about the diagnosis and how to do the diagnosis, how to do the testing is something that for which the scientific societies can help a lot.
I agree.
Lorenza, I have two fast questions. If the biopsy materials is insufficient for NGS analysis, in this patient, is it possible to use the liquid biopsy or not? Clearly, if is positive, is real, but is the liquid biopsy is negative, we have a doubt about the result. And the second question is the monitoring a patient during target therapy, the use of liquid biopsy is only in the study, or is possible to use in routinary clinical practice?
I'm happy to start, but I think that it's also important that the molecular pathologists will actually give us their opinion. I mean, I think that on the paper we still can't say the liquid biopsy is exactly the same of tissue biopsy, and especially this is, I think it's true in cholangiocarcinoma, when we are looking not only on gene mutations. Obviously, if we are looking for a mutation in ADH and BRAF, I think we are quite confident to call it through a liquid biopsy test. I think that the real challenge comes with the diffusions, which at the moment represent the majority of the targets which are druggable in cholangiocarcinoma. And I think that if you are it is feasible to do in the liquid biopsy, and I think the data from Leticia were quite promising and reassuring in some way. An 87% concordance between tissue and liquid biopsy was absolutely very good. I think that you probably depends on the knowledge about the partner of the fusion. So now we are increasing our knowledge, and probably we can screen better, but there is still a chance that you are missing something. As for the monitoring of the disease, obviously, yes, if we can detect the molecular alteration in the blood, I think we have the advantage of really understanding which is the clone that is driving the progression of the disease, and then we can see the response. I think the key question here is how really that will impact on the clinical management. I mean, we know that we might not have a lot of different drugs after, so do we really, how of benefit it will be for the patient. With the increase of the new generation FGFR2 targeting, for example, that can target also mutations that, are responsible for the resistance, that probably is quite a very good strategy to go forward.
The ESMO recommendation for these liquid biopsy in clinical practice has been just released, and I invite you all to read those recommendations, because we really highlighted all the good things about liquid biopsy, but also the limitations on the assay. Now, the point is that if you test circulating tumor DNA, you have a lot of limitations, generally speaking, in particular for fusions. First, there are some patients that will not release or will release very low levels of circulating tumor DNA. This means that we know that there is a fraction of no-shed patients in every cancer type. The cholangiocarcinoma is in the liver, so usually this makes easier the release of circulating tumor DNA in the blood, but still there will be some patients in which the genetic alteration are not detectable. Then the next point is that we sequence only circulating tumor DNA, and as I showed you for gene fusions, the sequencing of DNA might miss some of the fusions. This has been demonstrated in several trials. So we don't know really how much is really the coverage of these paths. They will tell you, oh, we cover the FGFR fusion, but how long, how many of the introns they cover and how long the regions they are covered, this is not clear. It's not, in many cases, not disclosed. So the suggestion is that if you have by any chance, if you did the test on tissue fails, you can go to liquid biopsy. If the patient is positive, can you believe in that? Actually, for the fusions, the specificity of the test is very high, so you can believe that. But if it's negative, there's still a possibility that the patient has the fusions and you are not detecting it on the liquid biopsy. For monitoring, I guess that if we will have available drugs that can work on resistant mutation, these will enter the practice. Now it's only a very nice exercise in the clinical trials. We have a couple of patients that we follow with liquid biopsy, but we have a research institute, so it's only for research purpose.
Thank you, Nicola and Chiara, for all. Thank
you. Pina, would you like to ask a question to our speakers?
Yes, thanks, of course. First of all, I would like to thank Professor Rimassa for the invitation. It's a pleasure for me to be here, and would like to congratulate Professor Chiara Bracconi and Professor Nicola Normanno for their exciting lecture. Well, we all know the difficulties in the diagnostic trial of cholangiocarcinoma. Then, as emerged in the presentation, many researchers recently attempted to identify biomarkers, new biomarkers, for early diagnosis with less invasive or non-invasive approaches on substrates such as plasma, stools, or bile. So I would ask to Professor Bracconi, which are, in your opinion, the most promising biomarker for early diagnosis with a favorable cost-to-benefit ratio, and very important, with an easy accessibility in small centers. Thank you.
Well, thank you. Thank you for the question. This is a very challenging question, I would say, because obviously there is a lot of research going on out there. I don't think we are on the rival line yet for any of the biomarkers that are tested. In my opinion, there are two challenges in cholangiocarcinoma. First of all, is that very similar to pancreas, we are talking about a population with vague symptoms. So it's going to be very, very difficult to validate our biomarkers for application to really the general population. And on the other side is the fact that I think probably the greater chances of success could be coming from a composite test. So I might be wrong, but I think it may be very, very difficult to have one protein, one extracellular vesicles, or one specific analysis that will give us the answer. And probably is the combination of different technologies that will help. We have seen the cancer-seq data that probably from the panel of the Johns Hopkins seems to be much more promising than others. I think that then the question is going to be the cost effectiveness, because obviously if we combine technologies together, the cost will increase, and then we really need to make sure that we are providing the patient with specific information for their management, and not just moments of worrying then has to translate in high cost for the healthcare system without a specific diagnosis. So I don't think that there is still one winner at the moment, but it's really good that there is a lot of research going on, and probably we will be able to get there.
Okay, thank you. Thank you so much.
Thank you, Chiara. There is a question from the chat. I think for all the panelists, and we can also, for all the speakers and panelists, we can also include Matteo and the others. What is the role of the molecular tumor board in the management of molecular information? Then we will have the third episode of this program on the molecular tumor board, but I think it's the perfect timing to introduce the topic.
Well, I can report in the UK, we don't have a specific molecular tumor board, and what we are trying to arrange is a national one, compared to differentiated molecular tumor board for each institution, because here the oncology is divided more by tumor type, so you tend not to discuss all the tumor type together. But I think that then it's usually driven by different drugs and access to the different drugs. So in cholangiocarcinoma, we are trying to attempt a general national tumor board where we can discuss all the cases.
Massimo, would you like to say something on the molecular tumor board?
My feeling is that even for this topic, as a clinician, I'm waiting for instructions at the local level, or how to access this opportunity in a regular fashion for our clinical activity. Because of course this should be part of our routine evaluation of patients in the present and in the near future. But at the moment, for instance, we have no this opportunity as a regular part of our routine practice in my institution, but I suspect in most of hospitals in my region. So it's a task for our oncological network at the regional level to give us instructions on how to avoid that our patients miss a chance of discussion that is very crucial for the optimal management from a therapeutic point of view. And so I suspect that this should be at the top of the list of the tasks to be implemented in an optimal way in our clinical practice.
Thank you, Nicola.
I don't think we really need a molecular tumor board to discuss standard genomic alterations that we find. I mean, if we find FGFR fusions or an ADH4 mutation, it's important that the patients discuss in a multidisciplinary team, in which you need to have the pathologist, the molecular biologist from the beginning. Most likely, if you find a rare mutation or if you find a complex genomic profile, those are the cases that should go to the molecular tumor board, which in our experience may represent less than 10% of all cases. Otherwise, the risk is that you are really bringing these cases to a board that does not really need to express the need for a treatment when it's clear the genomic alteration, and therefore the match therapy that patients should receive. So now I think that now in Italy we are really discussing too much at molecular tumor board, whereas we should really improve the establishment of multidisciplinary team for the handling of every tumor type, including cholangiocarcinoma.
Okay, So I think we are running out of time. I think we had a great presentation. Thank you again, Chiara. Thank you, Nicola. Great discussion. And I would like to remind the attendees that we will have 2 further episodes of this 50 minutes in September, the 15th and the 22nd, one on the therapeutics and the third one exactly on the molecular tumor board. So thank you again to you all and see you on September.
Thank you very much.
Bye.
Bye.
Thanks.
Thank you so much. Bye bye.
Siamo offline?
Sì, io non lo sapevo che eri offline?
La canzoncina è bella, sì.
Non ancora, prof, non ancora. Adesso stanno uscendo tutti i partecipanti.
Ah.
Grazie a tutti. Arrivederci.
Arrivederci. Ciao.
Arrivederci. Grazie a tutti.
Ciao. Ciao.
Ciao.